Good morning, everyone. So today we're going to talk a little bit about the spleen, kind of an organ that often gets forgotten until you run into a mass and you don't know what to do with. So we're going to talk a quick overview of splenic pathology and MRI. We're going to talk about the splenic manifestations of systemic diseases. We'll show imaging features of indolent and aggressive splenic lesions, and we'll talk about how to sort of approach it when you come across a splenic mass. Generally, when a splenic mass is encountered with ultrasound or CT, if the diagnosis is in question, you usually get a recommendation for an MRI, again, owing to its high contrast resolution and multiparametric nature. We run a standard abdominal and enhanced MRI multi-sequence, multi-planar protocol. Really, all of our just basic sequence, nothing special for the spleen. So normal spleen is going to be slightly T1 hypointense and slightly T2 hyperintense relative to the liver. That's the normal sequence, assuming the liver is not steatotic and is normal in signal. So spleen is always going to be a little brighter than the liver on T2 and a little darker on T1. In the arterial phase, you have this archiform enhancement that's characteristic, and that's due to differences in flow between red and white pulp, and eventually that normalizes. So we're going to cover these different types of splenic pathology, so developmental conditions. This is splenule. You see them abundantly, frequently on imaging studies, and I typically mention them, especially in oncology patients, so they're not mistaken for true pathology. This is an example of polysplenia, just multiple spleens, often associated with abdominal situs and cardiovascular anomalies, and in this patient, there is a left-sided IVC. For trauma, MRI is not going to be the first modality, but sometimes you'll encounter it. And this is just an example of a patient who had blunt trauma and who had lacerations, and you can see just the T1 shortening related to subcapsular hematomas and lacerations. Next, we'll talk about splenic involvement in systemic diseases. So this is a patient with sickle cell. You have autosplenectomy. The spleen is diminutive in size, and you see that on the in-phase sequence, there's blooming, there's loss of signal, and that's owing to splenic calcification. This is splenomegaly and portal hypertension. You got a cirrhotic liver, ascites, and an enlarged spleen. Gamma-Gandhi bodies are due to microhemorrhages, which result in hemosiderin and calcium deposition, followed by fibroblastic reaction. And typically, you're going to see them in portal hypertension. And again, T1 out of phase, T1 in phase, loss of signal on the in phase related to the iron content susceptibility artifact. So these are gamma-Gandhi bodies. This is transfusional siderosis. Notice on the T2 weighted sequence, the liver and spleen are really, really dark. You go to the in and out of phase T1 weighted sequence, and you have loss of signal in the liver, the bone marrow, and in the spleen, so the reticuloendothelial system with iron deposition from transfusions. Gaucher's disease typically has abnormalities in the spleen. It's the most common lysosomal storage disorder. It's autosomal recessive. And you can have a variety of appearances on the spleen. I haven't seen many of these cases. We don't have pediatrics where I work. But typically you'll have an abnormal-looking spleen with lesions that doesn't really fit into any category, but you'll typically know that there's a history of Gaucher's. Next, we'll talk about infection and inflammatory conditions. Believe it or not, I couldn't find an example of abscess in the spleen, so I got this from the literature. It's going to be no different than abscess elsewhere. You're going to have a fluid collection with a thick, enhancing, irregular rim. You may have restricted diffusion within the fluid depending on the stage of maturation of the abscess. Another thing I couldn't find, like candidiasis. So classically, you have microabscesses in the liver and in the spleen, and you're going to have numerous small lesions that are T2 bright non-enhancing, and sometimes with peripheral rim enhancement, so microabscesses and candidiasis. And that's going to be the most common infection in immunocompromised patients. Another one which we don't see a lot of here in the U.S. nowadays is tuberculosis, although I think there is a little bit of a comeback in some areas. But again, you have these complex cystic structures with peripheral rim enhancement, and this was an example of TB. This was a 41-year-old man who came in, had some incidental hypoattenuating lesions on a CT scan, ended up getting this MRI for further evaluation of these splenic lesions. And you can see that there are these subtle, mildly low T2 signal lesions in the spleen. I just magged this up in here in this patient. So low T2 signal, and they gradually enhance. This is sort of an early phase enhancement. You can see that they're behind, they enhance slower than splenic parenchyma, and they progressively enhance. And these were non-caseating granulomas. This patient didn't have all the features, but they were suspecting sarcoid in this patient. Next, we'll talk about vascular conditions. This is splenic infarct. This is more sort of acute to subacute, going to be T2 bright, wedge-shaped, broad base going all the way to the capsule, and non-enhancing. So we've all seen these on CTs for sure, and if you read enough MRs, you'll come across these. Now we're going to talk about sort of focal splenic masses, and we're going to go through all of these different lesions. So true epithelial cysts, i.e. cysts that have an inner epithelial lining, are uncommon, and they're a minority of splenic lesions. They're typically unilocular. And on MRI, they're going to be, just like any cyst, they're usually going to be T2 bright, low T1 signal. This one is T2 bright, but also had high signal on T1, meaning that it had hemorrhagic or proteinaceous content. But when you go to this digital subtraction, there's no enhancement. And this was revealed, this was resected and was revealed to be a true epithelial cyst. Most cysts in the spleen are going to be pseudocysts, usually related to trauma, infection, infarction, or other insult. They have no epithelial lining. Their composition varies, and they typically have some complexity. So here's an example of a pseudocyst. You have complex material inside, but when you go to and then when you look at the T1 weighted sequence, it's not T2 dark, so we know the contents are complex. But when you give the enhancement, the gadolinium, you have a smooth enhancing wall. So this is not an aggressive lesion, but it is a complex cystic lesion, and this ended up being a pseudocyst. Hemangiomas in the spleen are common, more common than lymphangiomas. So when you see lesions, typically they're going to be small, they look non-aggressive. On T2 weighted sequences, they look very similar to hepatic hemangiomas. Some of the articles really say that they enhance similar to hepatic hemangiomas. I find that they typically don't, actually. They usually just show this sort of low-level progressive enhancement, but that's what's in the literature here. Not been my experience, but they're very common. So most of the time when you're going to come across a T2 hyperintense lesion in the spleen with lobulated margins, something that looks like a hemangioma in the liver, that's typically what it is in the spleen. And what you'll see is that this is T1 fat sat before gadolinium, and then as it progresses, you get this progressive fill-in, progressive enhancement. It doesn't always become hyper-enhancing relative to parenchyma, unlike liver hemangiomas. So these are common lesions. And just keep this picture in your mind because we have things that look similar to this coming up. So next we'll talk about lymphangiomas. So it turns out lymphangiomas are actually fairly rare, even in the spleen. And they're going to be cystic in nature, so low T1, high T2 signal. They're going to be multilocular or unilocular, and they may have internal septations. So here's sort of your prototypic lymphangioma. It's a patient who had infectious mono and splenomegaly, and he had 3 of these. And so you have a T2 hyperintense lesion, well-defined margin, slightly lobulated, with all these internal septations that progressively enhance. This is another lymphangioma.